Welcome again to the series on surgery for undergraduates. Today's topic is acute pancreatitis, another important topic in general surgery. This diagram shows the general structure and location of the pancreas. It consists of two types of cells. It's made up of two main components. The major component is composed of acinar cells, which secrete the digestive enzymes amylase, trypsin, and lipase, which are responsible for the digestion of carbohydrates, protein, and fats, respectively. These acinar cells are directly or indirectly connected ultimately to the main pancreatic duct that runs through the backbone of the pancreas to carry the secretions into the second part of the duodenum. The other component, which is the lesser component, is known as the islet of Langerhans. This is shown in this area here. It consists of two types of cells, alpha cells and beta cells. The alpha cells secrete glucagon, which increases the blood sugar, and the beta cells secretes insulin, which decreases the blood sugar. So these two are very important endocrine glands in this pancreas. As for the pathogenesis of acute pancreatitis, the pancreas contains, as I said, exocrine glands that produce enzymes important for the digestion of carbohydrate, protein, and fats. Amylase for the digestion of carbohydrates, trypsin and chymotrypsin for protein, and lipase to break down fats. Acute pancreatitis occurs when there is abnormal activation of digestive enzymes within the pancreas. This occurs through inappropriate activation of inactive enzyme precursors called zymogens or proenzymes inside the pancreas, and most notably this occurs with trypsinogen. The pathophysiology of acute pancreatitis is characterized by a loss of intracellular and extracellular compartmentation due to an obstruction of the pancreatic secretory system and by the activation of the pancreatic enzymes which I mentioned. In short, noxious stimuli from various sources, including obstruction of the pancreatic ducts, lead to activation of trypsinogen, which increases the absorption of release of trypsin, which involves in the digestion of protein. And this excessive trypsin and inappropriate trypsin secretion causes autodigestion of the pancreas, leading to pancreatitis. One of the most common causes of acute pancreatitis is obstruction of the pancreatic duct by gallstone. Here this is the pancreatic duct to the second part of the duodenum, where there's a stone there at the ampulla of water, which obstructs not only the bile duct but also the pancreatic ducts, leading to stasis of pancreatic secretions in the ducts, which lead to the triggering of acute pancreatitis. The pathogenesis of acute pancreatitis, where the underlying cause of all the problems of acute pancreatitis is acinar cell injury, which can be due to indirectly by the obstruction of the pancreatic ducts by gallstones or chronic inflammation or tumors causing obstruction of the common bile duct and pancreatic duct. The second one is by direct injury to the acinar cells by alcohol, drugs, trauma, and various forms of other direct injury to the pancreas. And the third mechanism that causes is the defective intracellular transport of proenzymes within the acinar cells. And this is caused by metabolic injury, metabolic diseases, metabolic injury, instability of metabolic age in the body, and also by duct dilatation. Okay, so these three, pancreatic obstruction, acinar cell injury, and defective intracellular transport of proenzymes, all directly cause injury to result in injury of the acinar cell and release of the enzymes that causes autodigestion of the pancreas. Now we come to the causes of acute pancreatitis. The two common causes, most common causes of gallstones and alcohol use. Among the two, gallstone is the most common cause of obstruction leading to acute pancreatitis. In fact, together they contribute as high as 70 to 80% of the cases of acute pancreatitis. The other causes are drugs such as ACE inhibitors, azathioprine and furosemide, including estrogen, are commonly established causes of acute pancreatitis. Hypercalcemia is another important condition which predisposes to acute pancreatitis, especially in cases of hyperparathyroidism. Infection by viruses are very common, especially in children, mumps, and Coxsackie B viruses. Hypertriglyceridemia, there's a high level of triglycerides in the blood, also predisposes to acute pancreatitis. Injuries form another important cause for acute pancreatitis. Blunt injuries of the abdomen are a common cause of rupture of the pancreatic tissues, which leading to acute pancreatitis. And damage, injuries due to the pancreas caused by surgery or endoscopy, such as ERCP procedures. Cancer and other blockages of the pancreatic duct can also cause acute pancreatitis. Then there is conditions of hereditary pancreatitis, cystic fibrosis, or cystic fibrosis genes that are underlying causes for acute pancreatitis. Kidney transplantation, even pregnancy has been recorded as a cause of acute pancreatitis. Okay, this picture shows you the causes of acute pancreatitis and their incidence. As shown here, gallstones and alcohol contribute for 80%. Between these two, in our country, gallstones are more predominant cause compared to alcohol. The other causes account for 20%, which include abdominal trauma, medications, infection, tumors, genetic or anatomical variations of the pancreatic ducts, high triglyceride levels, and high calcium levels, which I've already mentioned. Besides the causes, there are also some risk factors to be considered. These are the 4 risk factors: excessive alcohol consumption, cigarette smoking, obesity, and family history of pancreatitis. What's the clinical presentation of acute pancreatitis? This upper abdominal pain, okay? Severe upper abdominal pain is the most important and predominant cause of predominant symptom of acute pancreatitis. The abdominal pain radiates to the back, is relieved by bending forwards or lying in a curled up position, and aggravated by lying supine. The abdominal pain feels worse after eating. So after eating, the patient feels the pain becoming severe. And often it is associated with nausea and severe profuse vomiting. The other clinical presentations will be fever, tachycardia, dyspnea, jaundice may or may not be present, tenderness in the upper abdomen, especially the epigastric and around the umbilicus. More to the left, gray turners and colored sign, which I will show you in a short while. And classically, the abdomen is silent. That means on auscultation, there's hardly any bowel sounds. Either they're decreased or absent. And blood count shows leukocytosis. Okay, this is the typical posture of a patient with acute pancreatitis. Okay, severe pain in the upper abdomen, and he sits in a stooping, bend forward position. The pain is the most important cause or most important symptom, which is acute epigastric or upper abdomen, mostly on the left side. The character is described as agonizing, burning, and continuous, and is usually refractory to normal analgesics. The degree is often very excruciating. It radiates towards the back, chest, and lower abdomen. The aggravating factor is supine position. He refuses to lie down in supine position. And relieving factor is sitting and leaning forward. If he has to lie down, he lies down in a curled up position, as you can see in the next slide. Okay, pain here on the left upper abdomen. The patient stoops forward. Okay, lying down in a curled up position with pain in the upper, applying pressure over to the upper abdomen. Okay, here same posture, curled up, and pain in the epigastric region. And these are the positions for the Cullen's and gray Turner sign. These are due to ecchymosis or blood-stained areas of bruising around the umbilicus, which is known as Cullen sign. And if it occurs over the back, over the lumbar region, then it is known as gray Turner sign. This is due to cases where there is hemorrhagic pancreatitis, and this blood seeps into the abdominal wall, causing ecchymosis, the front and lateral sides. Okay, this is the Cullen sign around the umbilicus, the ecchymosis, okay, due to the bruising of the subcutaneous tissues. And here this is on the lateral side, lumbar region, Turner sign. Cullen sign, Turner sign. Okay, this is gray Turner sign, where the back, the lumbar region is predominantly affected by this bruising. Okay, how do you diagnose acute pancreatitis? Acute pancreatitis is confirmed by three main methods. Medical history is very important to get a detailed history from the patient, followed by physical examination, and typically some blood tests, especially serum amylase and or lipase, which are the digestive enzymes which I mentioned earlier. Okay, these are the three things that you do to diagnose acute pancreatitis. The blood amylase or lipase are typically elevated 3 times the normal level during acute pancreatitis. Okay, this is important. Another condition, variation of the condition is called hemorrhagic pancreatitis. It is characterized by bleeding within or around the pancreas, and it is usually considered a late sequelae of pancreatitis. So these hemorrhagic episodes contribute to the gray Turner sign and Cullen sign. Okay, these are the triad of acute pancreatitis: typical abdominal pain, serum lipase and serum amylase are increased more than 3 times their normal limit, and characteristic CT findings, which I will show you in a short while. Okay, what are the differential diagnoses for acute pancreatitis? Okay, these are the 6 common conditions that mimic acute pancreatitis: perforated peptic ulcer, acute cholecystitis, ascending cholangitis, acute appendicitis, especially perforated appendicitis, acute intestinal obstruction, and acute mesenteric ischemia causing gangrene of the intestine. The types of pancreatitis can be classified as interstitial and necrotizing according to the pathological changes that take place. The more common is the interstitial type. Okay, the inflammation in the interstitial tissues of the pancreas, which contributes to about 90% of all cases of acute pancreatitis, and 20% of them, most of them are mild. Okay, 20% of them are mild severity and may lead to pseudosis formation with a mortality of 2%. So generally, interstitial is a milder form of acute pancreatitis, which lower mortality. The necrotizing type is a more serious or severe form with inflammation with massive necrosis of the pancreas and peripancreatic tissues. It contributes to 10% of acute pancreatitis. It's usually moderate or severe pancreatitis and may lead to shock and multi-organ failure. Okay, so these are the two that must be borne in mind. The revised Atlanta criteria for acute pancreatitis is very useful. Okay, when it gives you the classification as to mild, it classifies acute pancreatitis into mild, where there's no organ failure, no local complications, example peripancreatic fluid collections or pancreatic necrosis or peripancreatic necrosis. There's no systemic complications, no other organs are affected, and typically it's a mild form of acute pancreatitis that typically resolves in the first week of its attack. The second category is moderate acute pancreatitis, in which there can be transient organ failure. Okay, for example, you can go have renal failure, and which usually recovers within 48 hours. Or they can be complicated with some local complications like pseudosis formation or massive necrosis or abscess formation. Or the symptoms and signs are exacerbated due to comorbid disease that is present. For example, patient may have cardiac problems, diabetes, hypertension, and all sorts of metabolic problems that can act as to exacerbate the condition. Then the third category is severe. Okay, actually it's the same, similar to the moderate, but in this case, there's more permanent organ failure, which lasts more than 48 hours. And this can lead to multi-organ failure, and the mortality is very much higher. The ransoms criteria is another important grading system that's been used to determine the severity of pancreatitis. Okay, one is tailored for alcoholic or non-gallstone pancreatitis. The other one is tailored for the gallstone pancreatitis, which is more common. It takes into consideration at admission the age of the patient, the total white count of the patient, lactic dehydrogenase level in the blood, and AST, this is the liver enzyme, aspartate transaminase, which also is taken into consideration, and the blood glucose. So if they all raise above these levels, then you give each of them 1 point. And you monitor the patient and repeat the examination during the next 48 hours. Okay, there must be if there's a decrease of hematocrit more than 10%, blood urea increases more than 2 milligrams per deciliter. Calcium drops to less than 8 milligrams per deciliter, and the arterial saturation of oxygen falls below 60 mm of mercury. Phase deficit of more than 5 millimeters per liter, milliequivalents per liter, and estimated fluid loss about more than 4 liters. Okay, if this happens, each of them is also given 1 point. And the total point is from 0 to 11 points. 11 is the highest point where the patient is very sick, very ill. A score of 3 or greater predicts severe acute pancreatitis, and mortality is possibly higher. The other system which is commonly used these days, is the Apache system, which is the Acute Physiological and Chronic Health Evaluation 2 scoring system. Okay, the main advantage of this Apache 2 system is the score that can be derived at any time during the patient's hospital course of stay. Okay, you need not do on admission and after 48 hours. It can be done, the assessment can be done on the admission itself, and then you can grade the patient according to that. Okay, these are the parameters that are taken into consideration, similar to the Glasgow ransom score. In this case, a score of more than 8 indicates severe pancreatitis. Okay, so anything less than that can be either mild to moderate pancreatitis. Okay, these are the investigations that you want to do for the patient: serum amylase, serum lipase, X-ray abdomen, ultrasound the abdomen, CT scan of the abdomen, and endoscopic ultrasound of the abdomen. Okay, this is the plain X-ray of a patient with acute pancreatitis. It shows the classical colonic cutoff sign, where the transverse colon is dilated and is limited to the transverse colon, where the ascending colon and the splenic flexure are collapsed. Okay, this is due to inflammatory exudate in pancreatitis, which extend into the phrenocholic ligaments via the lateral attachments of the transverse colon. So because of that, the other parts of the intestine colon becomes collapsed except the transverse colon. And this localized, so-called localized ileus or dilatation is known as the cutoff sign, colonic cutoff sign, which is more or less diagnostic of acute pancreatitis. Okay, this is a close-up of the cutoff sign. Look at it. This is the transverse colon here, and the splenic flexure, hepatic flexure are collapsed. This is the ultrasound of abdomen, showing a very bulky, enlarged, and edematous pancreas here. Okay, this X here shows this is the pancreas with some peripancreatic fluid. Okay, this is another ultrasound showing you the pancreas. This is the pancreas, and the middle there is this hypoechogenic line here, which is the pancreatic duct, which is dilated. So a dilated duct in a swollen pancreas on ultrasound is more or less diagnostic of acute pancreatitis. This is the EUS, or the endoscopic ultrasound, which is much clearer to detect the stones causing obstruction at the ampulla, or the lower end of the CBD. Okay, and here the bile duct is grossly enlarged. Here another picture, CBD is dilated, and there is a stone here. Okay, so EUS ultrasound is becoming increasingly popular these days, but unfortunately it's not available in the smaller centers. Next is the CT scan. This is the CT scan showing the pancreas here, enlarged pancreas. Okay, can be measured, take measurements to see whether it's enlarged. The head here, the body and tail. Okay, and this is the spleen. Here again is the pancreas, pancreas here. Head, body and tail. This increase, thicken and edematous. Now the complications of acute pancreatitis. These are the common complications. Pseudosis formation is an inflammatory collection of fluid around the pancreas and the peripancreatic areas. Necrosis of the pancreas and the peripancreatic tissues. Secondary infection of this necrotic tissue leading to abscess, pancreatic abscess formation. Then you can have organ failure such as the kidney failure is another common complication. Respiratory problem leading to hypoxia is another common complication. In fact, all the organs can be affected, known as multi-organ failure, which is a complication of severe pancreatitis. Other complications include diabetes, especially if the beta cells are destroyed, malnutrition as a result of deficiency of the pancreatic enzymes, digestive enzymes. Patient can have diarrhea and weight loss due to malabsorption, and then chronic long-standing inflammation of pancreas can lead to pancreatic cancer. Okay, this is the acute pancreatitis, which always results in fluid collection. But I told you interstitial pancreatitis, which is the milder form of pancreatitis, and the severe form necrotizing pancreatitis. Okay, this in the interstitial type, there is a complication of pseudosis formation. Okay, about 6 weeks later, because of this acute pancreatic collection, which gets sealed off and then you form a cyst behind the stomach interior to the pancreas. The necrotizing causes massive necrosis of the pancreas and the peripancreatic tissues due to autodigestion by the enzymes. And later, it can either get infected or it can be walled off to form a chronic abscess known as the pancreatic abscess. Okay, this is a severe form of acute pancreatitis. Okay, this is a CT scan showing you massive necrosis here, pancreatic necrosis. This is the pancreas. The tail is okay. The body and the head is grossly inflamed and causes massive necrosis. This is a pseudosis, a complication of interstitial pancreatitis. Another collection of fluid becomes sealed off and has got a wall around it. And this is known as a pancreatic pseudosis, which takes about 6 weeks to develop. Okay, this one another CT scan showing you necrosis of the pancreas. And here, when there's necrosis, secondary infection causes an abscess here, which becomes walled off by the abscess wall. Now we come to the treatment of acute pancreatitis. The treatment of acute pancreatitis is very important, especially in the early stages, in the first 24 hours. First important is you have to replace the fluids and electrolyte. You have to be aggressive in the resuscitation of the patient with fluids because there's massive fluid loss due to severe pancreatic inflammation. Then you have to also look into nutritional support because the patient is unable to produce any enzymes for normal digestion. It can be enteral or parenteral. Parenteral is not very effective, but in fact it's more risky in these patients. So we try to go for parenteral, early enteral feeding, especially using nasogastric feeding. Pain control is another important. As I told you, the pain is usually agonizing in pain, excruciating in pain. So most of the time they need opiates, pethidine, morphine, high dose of infusion of morphine to control the pain. Then you have to treat the underlying issues. For example, if the patient develops renal failure, develops respiratory failure, or multi-organ failure, then you must treat them very aggressively, and the patient has to be sent to ICU for more close monitoring. Okay, and the patients, if it is cause is a gallstone, okay, you have to look carefully to do an early removal of the gallbladder. Then ERCP is another important procedure which gets to be done as soon as the patient is stabilized if there is a stone in the lower end of the CBD. Okay, you have to remove the stone before it triggers another fatal attack of acute pancreatitis. Then use of certain drugs like somatostatin, octreotide, PPIs, and antibiotics. Antibiotics are not given during the early stage. Is needed if there is fever and then if signs of infection. And it's very important for all cases of acute pancreatitis to be closely monitored, even on admission where they come as mild pancreatitis. Okay, if possible, monitor them in high dependency unit or ICU if necessary. The management of mild pancreatitis, this is a summary. Supportive care, fluid resuscitation, electrolyte balance, NPO, IV fluids, electrolytes, analgesia, especially morphine, and nutrition, especially if the patient is unable to tolerate any food and needs. Okay, you give him about 5 days, after which if you think you still cannot tolerate orally, you have to give some form of feeding, enteric feeding, nasogastric feeding. Okay, and a low-fat diet is very important. Important to give low-fat diet as the patient is not able to digest the fats. And you may have to control the vomiting, especially if the patient has got severe vomiting. So with drugs to stop this vomiting, otherwise you will not be able to feed the patient. Okay, in severe patients, you may have to have intravenous line access to monitor the patient, the strict IO chart. Surgery for mainly complications of the local complications of acute pancreatitis. Very rarely you need surgery for other reasons. Okay, the surgery can be definitive, usually after the patient is resuscitated, stabilized, and supportive treatment given. If the imaging mechanism, CT scan and ultrasound shows there's a stone blocking the lower end of the pancreatic duct, then ERCP should be considered as early as possible when the patient is stable, usually within 3 to 4 days, followed by laparoscopic cholecystectomy, because the gallbladder is the source of the stones that come to block the pancreatic duct. So laparoscopic cholecystectomy should be done as early as possible. If the patient is not fit enough, go for ERCP, remove the stone by sphincterotomy, and later when the patient is more stable, go for a laparoscopic cholecystectomy. For complications of the pancreatitis, surgery is usually required. Drainage of the pseudosis if it's big. If there's massive necrosis, you may have to go and do what you call necrosectomy. Drainage of abscess if it's already secondary infection. And these 3 procedures can be done endoscopically, laparoscopically, or by open surgery. The surgery that are considered for patient, first of all, is endoscopic ERCP and sphincterotomy, as I mentioned, followed by laparoscopic cholecystectomy. Endoscopic cystogastrostomy. Okay, this is for pseudosis of the pancreas. They drain, you create an anastomosis between the cyst and the posterior wall of the stomach so that the fluid can be drained into the stomach. This can be done by endoscopically or using under EUS guidance, endoscopic ultrasound guidance. The other method is to do a laparoscopic transgastric cystogastrostomy. So as I said, it can be either done endoscopically or laparoscopically. Necrosectomy, necrosectomy for massive necrosis of the pancreas and peripancreatic tissues. So this can be done by open method, but nowadays it's becoming more popular doing the laparoscopic method. And of course, if it's abscess formation, drainage of the abscess must be done. Okay, coming to prognosis, again depends on whether it is mild, moderate or severe. In mild pancreatitis, it is usually self-limiting. With adequate treatment and resuscitation, most patients will recover within the first week. There will be minimal organ dysfunction and uneventful recovery. So these patients, we have to, if you detect gallstones, a laparoscopic cholecystectomy must be done. Before which an ERCP should be also done. In patients with severe pancreatitis with local complications such as massive necrosis, pseudosis or abscess, and systemic complications like multi-organ failure, then they need a more elaborate resuscitation and management and monitoring in ICU. In such patients, especially with multi-organ failure, the mortality can be as high as 30%. Okay, so in summary, acute pancreatitis, two phases, early phase, late phase. Most of the patients with mild acute pancreatitis recover within the first week, and rarely they go into the second week. Severity wise, they can be mild, moderate or severe. Mild when there's no organ failure, moderate when there's organ failure which recovers within 48 hours, and severe failure where there's organ failure prolongs and is longer than 48 hours, and that causes high mortality rate. Pathologically, as I said, there are one edematous and necrotizing. Edematous is a lot of fluid collection, and this can lead to pseudosis formation after 6 to 8 weeks. Whereas necrotizing can lead to acute necrotic collection, which can be walled off to form a mass or secondary infection to form abscess. And the last slide here, I would like to show you the flowchart of the management of acute pancreatitis. A patient comes with acute abdomen. Clinical assessment is very important. History and physical finding, followed by serum amylase and lipase estimations and CT scan. So with these three modalities, you should be able to diagnose acute pancreatitis. Once acute pancreatitis is diagnosed, you classify them according to mild, moderate or severe. Mild, okay, is usually as given aggressive resuscitation, if possible admit to HDU, IV and electrolyte replacement, potent analgesia, especially opiates, nutritional support, probably with early NG feeding, nasogastric feeding, drugs, somatostatin, octreotide, proton pump inhibitors, and antibiotics if necessary. So the mild cases, with all this successful treatment, they will recover. Once they recover, you do a ERCP to remove the stone and sphincterotomy to remove the stone, followed by laparoscopic cholecystectomy. And this usually is done before the patient is discharged. Okay, because if you discharge, you may patient and another stone can pass down and cause severe acute pancreatitis, which can be fatal. In the moderately inflamed acute pancreatitis, okay, you provide the same type of treatment as in mild cases. Okay, but some of them will go on to develop local complications. Okay, they don't develop other organ failures. They develop local complications, pseudosis, necrosis, and abscess, which is initially treated conservatively. If fails, then you may go for surgery, cystogastrostomy, necrosectomy, and abscess drainage. The severe form of pancreatitis, okay, may develop local complications plus multi-organ failure. If they develop local complications, you treat them accordingly. If they develop multi-organ failure, then you have to treat very aggressively in ICU atmosphere and supportive treatment. And the mortality of these patients can be as high as 30%. Here the mortality is 5%, less than 5%, about 2%. Here can be high as 30 or more percent. So this diagram summarizes all the things that I've been talking to you during this lecture. I hope my short talk on acute pancreatitis would help you understand the topic better. Till I see you again in another topic in this series of surgery for undergraduates. Thank you for joining me.